it definitely adds a pucker factor because, we always are thinking, okay, we have to put a collar on them and do spinal motion restriction, but once you know there is an actual deficit and injury, it kind of ups things a lot more in terms of like, oh crap, this person has a spinal injury, right? And then, what if they start asking you questions? I can't move my legs. Am I going to be paralyzed?
I
What do you
don't
say?
know.
Ask the doctor.
Say, we don't know the extent of your injury yet. Okay? That's how it is now. It doesn't mean it's going to stay that way. Okay? Because you don't know, right? And they may not know for weeks, depending on what the injuries are. So never lie to your patients, but also try to offer them some sort of comfort. All right, so we're going to talk about the different kinds of spinal injuries and what's special considerations for older people, pediatrics, and other patient populations. Right. So, traumatic spine injury, usually from high energy forces. So again, when humans crash things and there's a high level of energy, whether that be car, bicycle, motorcycle, falling off things, diving into pools, whatever. Okay? If they have a head injury, you also have to suspect that they may have a spinal injury, right? Because it's all connected. Okay? And it may be a compression injury. So they hit their head on the windshield or on the roof of the car, that compresses your spine. Okay? And that can cause injury. It may not make them paralyzed immediately, but there's going to be swelling and all that, and they may recover, but it may take a while. Right? But if we don't stabilize their spine appropriately, then they can have a poor outcome. All right, so we can have complete or incomplete spinal injury. So I'm sure that you are all pretty familiar with what our vertebrae look like. And they are different at the different levels of your spine, right? What are the two special ones on top? C1, C2, right? Because it kind of like rotates in there. If you fracture that, are you gonna? Very unlikely.
But
Can it happen? Yes. Does it usually happen? No. Okay? Because that just like knocks out your breathing, right? And you can have an internal decapitation. That's crazy, but that can happen too. All right. So we've got our spinous process. We've got our vertebral foramen, so the whole of the middle, right? And the body of it. So they all stack on top of each other to make your spine. What's in between the bones? And the discs, right? Yeah. So it's got all the different tissues, but the cartilage between is the discs, which if you've been in EMS for any length of time, you probably have some damage to that. Okay. So we have our cervical or thoracic or lumbar. So the spinal cord ends where? What level? L3, L4 is where it kind of ends. So if you fall on your ass and break your coccyx, you're not going to have a spinal injury. Okay. So that's a good thing. But different levels will give you different signs and symptoms and different disabilities, right? All right, so we get called to a park. It's 82 out, 19-year-old female was swimming with friends at a local river in the park and dove off some rocks into shallow water. Always a bad idea. Right? Dispatch realized that friends pulled the patient out of the river when she didn't resurface. The patient's conscious but cannot recall the details of what happened. So, are we assuming she hit her head?
Mm-hmm.
Yes. Are we assuming she has a spinal injury? Also yes. Okay? And how are we going to document what happened before we got there?
Very carefully.
Now, we were not the ones that pulled her out of the river, that her friends did. Right? Alright. So, they can be life-threatening. Why? Well, it kind of controls things like breathing. Right? So, that can kill you. But it depends on where and if there's any structures around the cord that are damaged. Okay. So, this tells you basically where, below what the injury is, what will be affected, okay? So, if you get loss of sensation below the clavicles, that's usually a C4, C5. Okay? Nipples, that's like, translates into your thoracic vertebrae at the T4 level, anything below the umbilicus, T10, and then pelvic bone, T12. So people can be, paralyzed at different levels. Of course, depending on, like, obviously C4, C5 is worse because it affects everything, okay? Think about your nerves, right? Because everything is innervated and controls your blood vessels. So if you have a loss of communication to, like, below your clavicles, what's gonna happen with your blood vessels? They're not gonna work right. They're gonna be dilated, right? And you're not gonna be able to go to the bathroom, because your bladder's not gonna function, your intestines are not gonna function, you're gonna have to be on a ventilator, right? So lots of bad things. For our purposes, we can get somebody that's in spinal shock, okay? So everything below the injury goes and dilates, okay? So because they're so dilated, their pressure's gonna go down, but they're probably gonna be warm because everything's dilated, okay? Above the injury, their skin is gonna be probably cool and pale, and maybe diaphoretic, so you're gonna have two different skin temperatures, right? So you gotta check for that, or you're not gonna notice, right? Depending on where the injury is, they also may have trouble breathing because they can't take a breath. They can't move their ribs and their chest muscles, right? So they end up belly breathing because they're trying to do everything to breathe. Or they're just not breathing at all, so you have to breathe with them, okay? But you're gonna notice that, that's not normal breathing. Okay? Has anybody seen that? It's kind of wild. Right? But, so, how do we treat shock?
Lay them flat, keep them warm, high flow oxygen, Weevoos.
Yeah. So, give them fluid, right? Because they can't fix that dilation. So we're gonna have to give them fluid to keep their pressure up. Right? And constantly reassess them. Alright, so, scene appears safe, patient's friends are cooperative, answer all questions, nobody's drunk or on any drugs, which is amazing. There's towels and swimming equipment, along with plastic water bottles. No lifeguard. Patient's lying on the bank of the river and not moving. She's complaining of neck pain. So would this be a call that we could have in this area?
Yes.
Absolutely, right? There's swimming holes, there's Wapanews Creek, there's all kinds of places, right? So we could very easily have something like this. What are we thinking about the neck pain? You might have a spinal injury, right? Because their neck hurts, okay? Does everybody that has a spinal injury have neck pain? No. Sometimes they have shoulder pain, okay? Or they don't have pain at all. So you have, or they have pain that's greater someplace else, so they don't feel the neck pain. Right? So if there's what they call a distracting injury that hurts more, they may not be able to feel the neck pain. All right. So primary injuries occur at the moment of the initial impact. Secondary occurs afterwards. So they get swelling. The cord can get ischemic. There might be, if they broke any of the vertebrae, there might be pieces of bone that have impact So they may have to surgically go in and fix that and take pieces of bone out. We used to have a protocol where we gave steroids for spinal injuries. So that's not in protocol anymore, but they're probably going to get it in the hospital. Because that helps obviously with the inflammation. Alright, so you can have your spinal cord have a concussion just like your brain. So it's kind of like stunned. And the symptoms will eventually resolve. You can have a contusion, which causes bleeding or bruising. So just like your brain. So it depends on how much bleeding as to what the level of disability is going to be, right? And where it's bleeding. If the cord is compressed, the tissues may get ischemic. Right? And then if it's lacerated, you're pretty much done. Unfortunately. So, I don't think I told you guys this story yet. So, let's say that you're called to Bowden Park for a older male sitting in his truck, and they think he might have shot himself in the head. So you're told to stage. Okay. Cops get there and they're like, all right, you can proceed in, there's no gunshots. He's in the middle of the parking lot, and he's confused, and he has weakness to one side. So, what do you think? He could be having a stroke, right? That would be your normal thought process about that. But then, he starts breathing funny, and he gets weakness on the other side. So, now you're like, what the heck, right? But there's no damage to the truck whatsoever.
Is there
And he
any
doesn't
external
remember what
damage to
happened.
him?
Huh?
Is there any external damage to him?
Well, we find it on the top of his head. He has a small cut because what happened was he hit one of the concrete parking things with his truck, wasn't wearing a seatbelt, hit the top of his head on the roof of the truck, and caused spinal compression. Right? Thank God I put a collar on this man. Okay? And at that point we were still using backwards. Thank God I did that. Okay? So we got him out of the truck, and got him onto the stretcher, and there was much more belly breathing going on. And we didn't have to bag him, luckily, but in fluids, got him up to Mid-Hudson Regional, and he had a compression fracture. And he was fine after 6 months of rehab. But what a wacky thing to have happen, because you have no clues whatsoever but a tiny cut on the head, right? So that's why it's really important to do that secondary assessment to figure out what is going on with your patient, and reassessment, because initially only one side of weakness, and then it went to both sides. You're like, okay, this is no longer a stroke, right? Because you don't get that in stroke for the most part. So, yeah, crazy stuff. All right, so if your cord gets transected, it's very bad, and all functions distal to that section are lost. So you get paraplegia or quadriplegia. So para being 2 legs, usually bottom, or quad is all 4 legs. Okay. Incomplete is a little bit better prognosis, but there's a couple different syndromes. You can have an anterior cord syndrome, a posterior cord syndrome, or this Brown-Séquard syndrome, which is a really wacky thing, because they may have motor on one side, but not feeling. On the other side, they'll have feeling, but no motor. Yeah, it's wacky. Okay. So, it's a very strange thing, but it can happen. Alright. So, obviously, an incomplete transection is better than a complete transection in terms of recovery. Alright, so we talked a little bit about this. It can happen immediately, or it can happen over, 2 days. And that's why sometimes they're not able to tell people, you know, if they're gonna be permanently paralyzed or not for a week or so until everything kind of plays out, okay? Unless the cord's transected, then, like I said, you're pretty much done. But, we may see it because, like I said, everything below the injury vasodilates, so that's gonna cause them to be in shock. Alright, so, you can get bradycardia with this, venous pooling. So if you suddenly see your patient become more bradycardic, their pressure goes down, they're going into spinal shock, right? So give them those fluids, keep them warm, and get them to the hospital quickly. You know, you hopefully don't have to do anything in terms of a pressor, but you might have to, okay, depending on how far you have to go. Alright, so, back to our patient. No severe external bleeding noted. The airways open at patent, fast, normal chest rise. Slow, thready radial pulse. Skin is flushed and warm. So why is that?
It's a dilation.
Right, it's a dilation, right? GCS is 10, so eyes are open, she's a little confused, but motors only 1. And there's an abrasion to the forehead, so that's probably where she conked her head, right, on the rock. Alright, so, make sure that you're checking for movement and sensation, right? Can they feel, can they move, alright? We don't have things to really check for vibration. You know, the neurologist is gonna do the full-on neurological assessment. Can you feel temperature? And if there's any difference, sure. Right, you can feel that through your gloves. Is there a difference in limbs? Is there a difference in lower body, upper body, right? Alright, so, vital signs of heart rate's 54, SpO2 is 97, end tidal's 42, restore rate's 20, and she's 82 on 50. The map of 60. Do we like that? No, we really don't. Okay. What are we gonna do about it? Fluids, right? Keep her warm, fluids, that's, you know, pretty much, and tell the hospital what you have. So they're ready, okay? And they get neuro involved, like, quickly, right? There is pain on palpation to C5 and C6, but there's no deformity or crepitus, okay? When you should feel each level and each vertebrae. And if you feel, they call it step off, okay? So if you're feeling down somebody's back and all of a sudden, like, there's an indent that's not supposed to be there, okay? That's kind of like step off, so that's indicative of a fracture. Okay. So you should feel and ask if they have pain all the way down the back.
Sorry. Yeah, I don't know why it's
Is that
doing
like
this.
Galaga?
I don't know.
Patient can't move their legs. And they also can't feel or move their arms. So she can't feel or move her arms or the legs. So, if somebody is awake and aware, do you think they're going to be a little upset? Hell yes. Okay? So a big part of our job is providing as much comfort as we can without lying to our patient. Okay? Because they're going to be freaking out about this. And rightfully so, right? It's even worse if you're like trapped in a car with them, or, you know, someplace that you have to extricate them from, because you're with them longer, so it's harder on us as providers, because that's a really stressful situation. Now, the injury did not happen to us, thank goodness, but it's still stressful for us to provide that comfort and emotional support to that patient, as well as the medical support. All right, so, can we clear the spine in this patient? Obviously not. How do we do that? How do we know whether somebody needs a collar or not? what are some of the things we have to look at?
Mechanism.
Mechanism, what else?
Ultimate status.
What's their mental status? Are they alert or anti-tension? Okay. What else? Pain, do they have any pain on palpation? And,
Check the stick log.
yeah. And do they have any distracting injuries? Okay. And they can't be impaired by anything, like alcohol, drugs, whatever. Okay. All right. So, and obviously that they have equal, sensation and motion and everything in all the extremities, and no tenderness. All right, so, do they have other injuries besides the head and spinal injury? Alcohol and drugs can mask their pain, okay, and alter their perception of pain. So, all right. So, is the patient reliably able to tell you what's going on? Okay. Obviously, blunt trauma with falls being the main problem for spinal injuries and would get the crashes. Penetrating injuries used to be we board and collared everybody. Now, you know, the studies show that it's really not necessary to do that. So, you know, somebody's shot, they don't automatically have to have spinal motion restriction. Right? Or stabbed. Now, if they're blown up and have penetrating injuries and like, you know, were thrown into a wall, yeah, you kind of want to do that. Right? All right, so indications: blunt mechanism, sudden deceleration, fall from any height, especially geriatrics, ejection or fall from a motorized vehicle, shallow water events, head injury, helmet damage, blunt injury to the torso, impacted or deceleration, fracture of the legs and hips. When does that happen? Usually. What kind of issues? Okay, yeah, they're beat up on the dash, or motorcycle riders, right? Their femurs hit the handlebars, right? Or localized injuries to the spine.
Can I ask 2 questions?
Yes.
Fall from any height, does the protocol say 3 feet or higher?
This is a national course,
I'm just asking that again.
okay, and they will, each region will have their own kind of protocols as to what they consider a, significant height. But, again, grandma can fall from standing and break her pelvis, right? So, if it's somebody that's not a geriatric patient, you know, you don't necessarily take them to the trauma center. It depends on the situation, okay, and that's why we assess your patient. So, in our protocols, it does have, I think it's 10 feet, it might be 15, I don't remember off the top of my head, is considered a significant height. You guys remember?
I think it's 10 for kids, 20 for adults, is that what?
Yeah, something like
I
that.
think that's like the hospital.
For like a level 1, indication for a level 1 trauma center.
Right, but
Yeah.
I think that, I'm trying to look at my
Are we talking about when to use a cervical collar or when we're gonna call a trauma?
a cervical,
trauma
spinal
alert?
motion restriction, cervical collar.
Oh,
Oh,
Yeah, so fall from any height, especially geriatrics, I think is fair, cause we've all seen little old people who've broken bones, with super brittle bones. Fall from standing height can be devastating for them versus if you fall from standing height and I try to put a collar on you,
Yeah.
I'd expect you to resist. You know,
Right.
So that's like, that's judgment kind of thing.
I think the New York State protocols take a fall from greater than 3 feet.
Okay,
And I'm just asking
yeah,
because we have.
honestly, I don't remember off the top of my head.
We
I
had a
thought
case like this in the
talking about when to
hospital.
call a trauma, the 10 and 20 feet, not if you.
And the second question is localized injuries to spinal column. Do we suspect cervical trauma if the injury is localized to somewhere else in the spinal column because of the fact that like if they have thoracic pain or lumbar pain, could we suspect that it could also be cervical, or would we say no, unless it's localized to the C-spine, we don't consider
Well,
C-spine stabilization.
so, let's think about that. If they have an injury to their lumbar, okay, that could be significant, they have some deficits. Would you want the spinal column to be the whole column to be in alignment?
I agree, yes.
So, just as a precaution, I would try to keep I would do spinal muscle restriction. Just because you don't want, because anytime you bend one part of it, you're gonna bend another part, right? So you wanna keep it all in
We
mind.
had a case like this at the hospital Saturday night.
Well, tell us about it.
Okay, do you wanna tell the story?
You were there too.
Sounds like you brought it up.
Yeah.
Yeah.
It's been a.
You want stuff.
Yeah, he wants
Right,
to.
It's emotional.
Traumatized?
I've been hearing about this all.
Person was out, rock climbing, but they were just jumped from one boulder to another boulder.
Okay.
Fell 3 feet.
Okay.
They weren't actually climbing, they fell 3 feet. Hit their head, had hematoma on the left occipital region of their head.
Okay.
Initial ultramental status, but were fine by the time EMS showed up on scene.
Okay.
Lower lumbar, tenderness. EMS showed up on scene and she was walking around ambulatory moving her neck, so they did not use the C-collar. We brought her in, but it was a level 2 trauma activation at the hospital.
Mhm.
Our initial thought was, why did she not have a C-collar on? Statement was she cleared because she was walking around ambulatory, she fell from 3 feet, so that's kind of on the borderline, and she was moving her neck. Ultimately had an L5 fracture to her. So the argument, is somebody I know who brought it in between me and them is, well, she shouldn't have had it because they caused greater trauma to have a C-collar on, blah, blah, blah. Talked to the trauma surgeon said absolutely she should have had a collar
Pulling on her
on.
immediately anyway.
Right.
So it's been a big subject of debate between.
Well, I
the
mean, she had
agencies.
obvious trauma to her head,
Right, which is indicative to me
Right.
that she should,
and she had a distracting injury, so you can't put her spine.
right.
That sounds more like a misunderstanding, so probably happened with backboards.
Right.
Backboards were shown to cause more damage because people were laying on it for long periods of time and shifting.
Yeah.
So if you had a spinal injury, you're just hurting yourself more trying to make yourself comfortable on it. But a collar,
Well, I think he pulled the research, there's like lots of research to talk about not using C-collar anymore. He pulled the research that shows that C-collars can cause an increase in ICP if it's a selective ICP, and can cause, pressure ulcers. But those are the only two things, and of course, it's not indicated in a 21-year-old who falls in the trap, unfortunately, but.
And, you know, we still use the hard collars, whereas Europe, they're using soft collars.
Right.
So, you know,
I'm just trying to figure out.
Also ask yourself, fall, alter mental status.
yeah,
I agree 100%, but I'm.
That's not even a debate, that's not a question, because you know what can happen. You get to the hospital, tell the doctor, and they're like, okay. That's fine. Let it be on them.
Yeah.
So you can put in your chart, if the patient was placed in an appropriately sized C-collar as a precaution.
Okay.
right.
How long does it take to put on a C-collar?
Yeah, I agree.
You know what I mean? It is
Well-
one of those, it's so cheap, it takes a few seconds, and it can save you a world of pain, litigation-wise.
Right, and just make sure it's the appropriate sized
Sure.
collar, because you can cause more damage if it's too big or, you know, not appropriately placed.
He was quoting New York State protocols that said 3 feet or greater, 2 feet and all that stuff.
Yeah, but
Protocols.
protocols are protocols, they are guidelines, right?
that's judgment, right?
Yeah,
Jay, that
Or
sounds
clinical
way cheaper
judgment.
to group too.
Or if you don't wanna use the C-collar,
Greater than 3 feet,
Right.
5 steps for the patient's
Right,
head.
yeah, that's right.
Yeah.
what if you know, going, playing devil's advocate, you don't wanna put a hard C-collar on it, let's say, it might cause more harm, you know, by still manipulating them, what else could you do?
Oh, the little bit block on it.
There you
Yeah,
go.
yeah, yeah.
And then what do you say? Based off of the mechanism of injury and this, that, and the other, and, you know, certain inability to place a hard C-collar, C-spine was still secured with a soft spline. Hand towel around the neck with tape, a blanket, like, you know, I'm not saying even a backboard and head blocks on this guy, but like, come on.
all right, so,
We launched the website.
this whole list, signs and symptoms. Obviously, if you have any of these, they're gonna need a C-collar, okay? But, that's a great case in that, judgment is really important, okay? So, the patient you were talking about, they might have a normal level of consciousness now, but initially they were confused, okay? There's evidence of a head injury. Falling on rocks are very hard, right? She had spine tenderness. Did he find that? in the
I-
assessment?
yeah.
Okay. So there's a So there's tenderness, they were not intoxicated, I assume, or doesn't matter. So she had some neurological findings and that she was. So, yes, that, and they will, roast you in like a trauma review if you do not put collar on that. Alright. So, spinal motion restriction follows the principle of fracture management. Immobilizing the joint above. Okay. Don't use, yeah, okay. See, there are different places do different things. For the most part, we don't use boards anymore because they can cause more injury, right? If the patient is awake, they can keep their neck in line and do a better job than we do, okay? So put a collar on them and they can keep themselves in line. Scoops are great, because you don't have to move the patient that much, right? So you can put them in a scoop with a collar. And then of course there's a vacuum mattress, if you work someplace that actually has a budget, and can afford to buy equipment. Those are great because it pads all the voids and they really don't move, you know, so those things are great, if you have them. So if you have somebody that, you know, you suspect does have a spine injury, those, I would love to have one of those because you know they're not gonna move, right? And especially with, you know, some of the roads,